The difficult thing about neonatal seizures is that babies make so many unusual movements anyway, so it's often really difficult to differentiate whether something is a seizure or whether it's just like a regular baby movement. That's very different to older kids or adults. For example, if we were having a conversation and I just started randomly smacking my lips or like pedaling my feet rhythmically, immediately you'd recognize that something was going on. Unfortunately, though, seizures are relatively common in the neonatal period. In fact, they're more common then than at any other moment in a person's life. About 1 to 5 in 1,000 live births, 1 to 5 babies in 1,000 live births will have a seizure. That number goes up even higher in preterm babies. It goes up to 15 babies in 1,000 live births. So really pretty common. And in babies, most of the time, these seizures are provoked. So there's something that's actually causing it. And the most common cause in a term baby is HIE, or hypoxic ischemic encephalopathy. And a preterm baby, the most common cause is an IVH, or intraventricular hemorrhage. We've all taken care of infants with seizures. And as you all know, they very rarely look like we'd expect them to look, like that kind of like rhythmic jerking. Most of the time, we're all like standing by the bedside trying to decide whether the weird apneic spells or that kind of weird twitching is actually a seizure or not. And again, that's the complicated thing. Seizures can present in such different ways. Hello, I'm Dr. Tala, and I've been a neonatologist for 17 years now. And today we're going to be talking about seizures. Our channel members voted for this topic, so if you want that type of power, then consider joining our lovely community. The details are below. Because there was so much to cover about seizures, we decided to break this up into 2 different videos. So in this first video, we will cover 1, what is a seizure? 2, what are the different seizure types and how do they look clinically? And 3, how a seizure is diagnosed. In the next video, we'll cover what causes seizures, how do we go about discovering the underlying cause, how do we treat seizures, and what is the prognosis of a baby having a seizure. Let's get straight into it. 1, what is a neonatal seizure? Well, a neonatal seizure is defined as a seizure that happens within the first 4 weeks of life, or if the baby was born preterm, then it's a seizure that happens before 44 weeks gestational age. And the seizure itself is defined in neonates as a sudden, abnormal, synchronous, which means it's happening at the same time, and rhythmic electrical activity in the brain with a repetitive and evolving pattern on EEG, which is the electroencephalogram, lasting at least 10 seconds. So basically, there is uncontrolled electrical activity happening in the brain. And we'll talk a little bit more about that electricity or that electrical activity when we talk about EEGs later. For now, just understand that the neonatal brain, especially the premature brain, is much more vulnerable to getting seizures because of the immaturity of the brain itself. More specifically, the neurons in the neonatal cortex have increased excitatory potential and decreased inhibitory activity, which means they are much more likely to fire more freely than a more mature neuron. Another important thing that you need to realize about neonatal seizures is because they don't have much myelination in their brains, the seizure activity is much less likely to become generalized. A generalized seizure in older kids and adults is considered generalized when it starts and involves both sides of the brain, so both hemispheres, and it's normally associated with a loss of consciousness. So in babies, they're much more likely to have focal seizures that don't spread. And if this abnormal electrical activity doesn't reach the motor cortex, remember the motor cortex is the area of the brain that's responsible for the movement of our body. If it doesn't reach the motor cortex, then we're not going to have any of those movement signs that we would normally associate with seizures in older kids and adults. So because of this, the seizures are much more likely to be subtle. 2, this brings us to what are the different seizure types and how do they present clinically? But before I go on, I do want to go over this. And that is because the baby does have an immature nervous system, there are many movements that a baby can do that really can look like they could be having a seizure. And I know that you've all seen most of these. One of these is jitteriness, and you've all seen this, that very high frequency tremors, normally of either the hands or the feet of babies. And we see it when babies have hypoglycemia or hypercalcemia or withdrawal or whatever. And you can see that often it's elicited by something. So if you unwrap the baby will start jittering. Importantly, if you hold the baby's hand, normally you can stop that jittering from stopping. And obviously it's not going to be associated with any other autonomic changes or anything like that. Another movement you might see, which may be concerning for a seizure but isn't, is tremors. Tremors are kind of like, have the same etiology of jitteriness, and a lot of the things that cause jitteriness can also cause tremors. A baby being cold can also cause a tremor. A tremor has slightly higher amplitude, so it's like more movement than the jitteriness, and a slightly lower frequency. Generally, though, with tremors, the amplitude or the overall movement won't be as high as with an actual seizure. So it's going to be more like this, whereas a seizure is going to be more like that. If you also notice the difference between my little movements here, with a tremor, the going back and forth is a lot more symmetrical. With a myoclonic seizure, generally there's a fast stage and then a slow one, and a fast one and then a slow return to baseline. Again, same thing as with jitteriness. Tremors are normally elicited by unwrapping the baby or by something else going on, the baby being cold. And again, you can normally stop it by holding the baby or wrapping up the baby again or repositioning or whatever. And again, we would not expect the tremors to be associated with autonomic changes. So there are not going to be DSATs or bradycardias or anything happening with the tremors. And then another movement that we might see in babies that can be completely normal is myoclonus. And that is often happening when the babies are asleep. And it's when they do this sudden kind of jerky movement when they're asleep. And I always tell parents that it's really very similar to sometimes what we get when we're just about to fall asleep, and we'll do that sudden kind of jerkiness as we're like drifting off to sleep. Again, this can be really scary for parents. It doesn't really look like a seizure. They'll just kind of do it once, and then maybe several seconds they'll do it again or not. Obviously, if that keeps happening in a rhythmic jerking type way over and over again, it is more concerning. But most of the time, it's just a usual myoclonus in a sleeping baby. So that's one complicating factor, trying to figure out if something is a seizure or not. The other complicating factor, like we already alluded to, is that most neonatal seizures, nearly all neonatal seizures, are focal, which means that they only cover one area of the brain. And if that doesn't include the motor cortex, then we're not going to see any movements at all. So we don't even necessarily suspect the seizure. But if you put an EEG on, then you will see that the baby is having abnormal electrical activity. This is what we call a subclinical seizure, when we have abnormal electrical activity, but no obvious abnormal movements from the baby. In fact, it's estimated that about 80% of neonatal seizures are subclinical, which is a pretty astonishing number. Or another way of saying that is that if you only get an EEG on babies that you think are having a seizure, then you will miss 80% of them. Because of this really high incidence of subclinical seizures, a lot of organizations recommend that if a baby is at very high risk of having a seizure, for example, they have HIE or meningitis or a really bad brain bleed in a preemie baby, then they recommend actually getting like a screening EEG or keeping an aEEG on the baby to make sure that we're actually not missing subclinical seizures. Having said all of that, if a baby does have signs of having a seizure, how can they present clinically? So that's what we're going to cover now. The first way that babies can present is with automatisms. And this is really difficult to figure out because they're all things that babies might be doing anyway. An automatism is a non-purposeful, stereotyped, repetitive behavior that the baby just carries on doing, normally not from their control. So it's done with an impaired consciousness. So it's things that can involve the face, for example, like the mouth, the lip smacking that I talked about earlier. So, or it can involve the tongue. So the tongue is just constantly coming out like in a repetitive pattern. These aren't things that you are able to stop because it's a seizure. It could also involve the eyes. So we get this like constant eye deviation. Again, sometimes a baby could be doing that, but in this case, it is non-purposeful. Automatisms also include the progression movements in baby's extremities. So sorry, my baby's upside down here. But for example, the pedaling movement that we sometimes see babies do, or like more of a swimming movement. Again, sometimes babies do this normally as part of their usual movements. But if it's continuing and it's repetitive and you can't stop it, then it's a lot more concerning for it to be a seizure. 2, babies may present as having seizures with just having autonomic changes, which is where they have sudden changes in their autonomic system. So these are the babies that might suddenly stop breathing and they present with apnea. Babies might also just have pupillary changes or vasomotor changes, so different kind of patterns of blood supply to different extremities in their skin. Or babies might suddenly get too hot or too cold. These are all changes in the autonomic system. Definitely the most common would be a baby just presenting as an apnea, and that is actually because they're seizing. 3, clonic seizures. These are the ones that we always think about when we think about somebody having a seizure in a movie or whatever. And that is that like repetitive jerking movement of usually of the extremities. It can be just one side or it can be bilateral. Like we said already, the difference between these clonic seizures and the tremors that we talked about earlier is that with the clonic seizures, there is normally a rapid phase and then a slower return to baseline, a slower phase. Whereas with the tremors, the jerking is a lot more symmetrical. Generally, clonic seizures are the easiest to recognize. They are also the seizures clinically that are most likely to correlate with a seizure on an EEG. And these are the types of seizures that are often seen with a neonatal stroke or with an IVH in a premature baby. So basically, if you do see that rhythmic activity like that with the faster phase and then the slower phase back to baseline, then it's a very good chance that the baby is having a seizure and will correlate with an abnormal EEG and will likely need treatment. 4, a myoclonic seizure. This is pretty difficult because we have to differentiate it from the myoclonus that we talked about earlier. If you remember, we said it happens when babies are asleep and it's just like this jerking movement. It could be of their whole body. A myoclonic seizure is obviously associated with an abnormal EEG. Again, it's a very brief contraction of the muscles. It normally lasts less than 100 milliseconds. The difference is that with myoclonic seizures, it's unlikely that it's just going to happen once. More likely it's going to happen more than once, and it happens in more of a rhythmic pattern. So it's not just once and then maybe 5 minutes later the baby does it again. It's more likely that the baby does it and then maybe a few seconds later the baby will do exactly the same muscle contractions again. So basically, if you notice that that myoclonus keeps happening, then you should definitely be getting an EEG. This type of seizure is more common in an inborn error of metabolism or sometimes in preemie babies with bad head bleeds. 5, a tonic seizure. And think of tonic because it's like increased tone, because that really is what a tonic seizure is. It's an increased sustained muscle contraction for several seconds, normally at least 3 seconds, up to like several minutes. So this is a type of seizure in that it would be associated with an abnormal EEG. So normally this is just in one extremity. And the reason why it's important to note that is that we talk a lot about the posturing, the hypertonic posturing in babies. And that normally is not a seizure when their whole body is involved. Again, remember, babies rarely have generalized seizures. So if the whole body is stiffened up for several seconds or however long, baby probably does have something abnormal going on in the brain. But if it's the whole body, it's less likely to be a seizure. A tonic seizure is more likely to happen just in one extremity, or it could just be the trunk that's stiffening up for a little bit. There are a few other types of seizures. For example, a behavioral arrest, where basically the baby just freezes, stops doing everything, including breathing. Or there could be a sequential type of seizure where the baby's doing one type of seizure and then it kind of goes into something else. Or it could be unclassified, where the type of seizure the baby's having doesn't really fall into any of these groups. Generally, depending on the type of seizure that the baby is having, they're more likely to manifest different types of symptoms. But nothing is consistent. So just get used to noticing all these different types of abnormal movements and being able to differentiate them from like the jitteriness, the tremors, the myoclonus, the normal myoclonus. 3. How are seizures diagnosed? Well, if you've been listening at all so far, you'll realize that it would be very important to get an EEG to actually diagnose a seizure. Like we said, a lot of seizures are subclinical, so they don't have any clinical signs at all. And the other thing that we said is the other complicating factor is that a lot of abnormal movements that babies do can also look like seizures. In fact, there was an interesting study that was done where a variety of neonatal movements videos were shown to neonatal experts. And they were asked, is this a seizure or not a seizure? And only about 50% of the time were the movements correctly identified as being seizures or not seizures. There was also a lot of variability between what all the different experts said. So yes, it is very difficult to actually identify whether a baby is having a seizure or not. Also realize that a lot of the things that can cause abnormal movements in babies, whether it's jitteriness or whether it's apnea, can also be caused by abnormalities in the baby's body. So, for example, hypoglycemia can cause jitteriness. It can also cause a seizure. A bleed in a preemie baby can cause that baby to have apneas or could also cause the baby to actually have seizures. So that kind of further complicates the picture. So to repeat it all, obviously to actually diagnose whether a baby is having a seizure or not, you need to measure the baby's brain electrical activity. And the way that we do that is with an EEG or an electroencephalogram. Okay, very quick review of brain electrical activity here. Remember that brain cells or neurons communicate with each other with electrical signals, which are very rapid and very short-lived. These electrical signals, also called action potentials, if you remember that phrase, are generated by the movement of ions across the neuron's membrane. When the action potential reaches the end of the neuron and it needs to communicate with the next neuron over, when that action potential reaches the end of the neuron, it triggers the release of a neurotransmitter, which is a chemical messenger, which then travels to the next neuron so that message can be continued. So basically, EEGs are just measuring that overall electrical activity, or basically the different total action potentials in the brain. And as I'm sure you remember, depending on the state that a baby or a person is in, then we're going to have different electrical activity given out by the brain. In babies, neurologists generally divide that different electrical activity into kind of 3 groups. There's the awake active group, and then the other 2 are when the baby's asleep. So it could be asleep in REM sleep or sleep in non-REM sleep. So really kind of 3 phases. What the neurologists are actually looking for on the EEG when they're looking for seizures is abnormal electrical activity that doesn't fall into one of these expected states. The International League Against Epilepsy, and the acronym for them is the ILAE, they recommend and they also emphasize the importance of getting an EEG to actually diagnose these seizures based on everything that we've talked about. They also really recommend that the ideal thing is getting a video EEG. So we're actually filming the baby as we're monitoring the electrical activity of the brain to see if there is any clinical activity or any movement or apneas or anything happening with the baby that correlates with the abnormal electrical activity. Although, as we all know, getting a full EEG, especially a video EEG in the NICU, is not always that easy or that quick. And when we say a full EEG, it is run and checked by the specialist, specifically the neurologist. So if you can't get a full EEG, then it's recommended that we get an amplitude integrated EEG, which is kind of like the smaller, faster version of an EEG. Normally, there's like 3 to 5 electrodes being used, and these electrodes can just be kind of stuck onto the scalp, or we can use like little micro needles. They're very easy to apply. We don't need specialized neurology trained technicians, and they can normally be interpreted by all of us at the bedside. So they are a pretty good alternative. The good thing about aEEGs is that they are pretty specific. If we see a seizure on it, then we can be pretty certain that that really is a seizure. And I'm going to find a way to actually go through the different types of aEEGs monitors, and we'll discuss kind of like the brain activity. We'll do that on a live model. So yes, the aEEGs are pretty specific at actually diagnosing a seizure. Unfortunately, they're not that sensitive. And you would expect that we're probably going to be missing some seizures. We have fewer electrodes. So if there is a very small amplitude seizure, or it's happening in a place further away from the electrodes, then we're probably going to miss it. Actually, in one study, only 38% of the seizures were picked up on the aEEG. Honestly, other studies have been done that show a much higher sensitivity of that. So they're picking up a lot more of the seizures than that. It would probably really depend on the type of seizure the baby is having, as well as who's reading it and the electrode placement. Just so that you all know, an aEEG is not as sensitive as an EEG, but it's still better than nothing. Often we just keep the aEEG on babies. For example, the whole time a baby is being cooled, often until they're being warmed back up again after having HIE, we'll just keep the aEEG on the baby just because they're at such high risk of having seizures. When we're using EEGs, it's also recommended that we actually keep them on the baby for at least an hour. If we think that we're missing a seizure or something is happening in a period that doesn't happen within that hour, then we'll go on to record a baby for 6 hours or even 24 hours. And then if you do see a seizure, then it's recommended that you keep monitoring the baby on the EEG until the baby has been seizure free for 12 to 24 hours. The other important thing I want to say here is that sometimes if a baby is being diagnosed to have a seizure and you give them an anti-seizure medication, or it's also called an ASM, you give them an anti-seizure medication, it's possible that there is uncoupling, which means that the medication stops the clinical signs of the seizure, but the baby is still having electrographic changes on the EEG. So is still having the subclinical seizures. So you can't just depend on whether the baby stops having clinical seizures when you actually give a anti-seizure medication. What do we see on the EEG? Well, obviously, I'm not a pediatric neurologist, but I am hoping to speak to one very soon. But just so that you all know, the American Clinical Neurophysiologic Society defines a neonatal seizure as a sudden abnormal EEG event defined by a sudden and stereotyped repetitive waveform that evolve in morphology, frequency, and or location with a minimum 2 microvolt peak to peak voltage, and it has to be more than 10-second duration. So basically they're saying it's repetitive, it has to have a certain amount of electrical activity increase, and it has to last a certain amount of seconds. We will get the pediatric neurologist to talk more about this. When I'm looking at the aEEG, what I'm looking for are large spikes that happen above the background activity that don't seem to correlate with any movement or anything else that's happening with the baby. Again, we'll go over aEEGs in a separate video. Like we already said, video in addition to EEGs are great, or also polygraphic EEGs, where like eye movements, respiratory movements, muscle movements are also being measured, are also great because then they can also correlate with the abnormal electrical activity that you're seeing on the EEG. There are recommendations for treatment depending on the clinical symptoms as well as EEG findings. So if you see a seizure on an EEG and baby is clinically acting like they're having a seizure, then definitely at that point you should be treating the baby. These are the recommendations published in the New England Journal of Medicine. I'm not going to go over the details here, but also just realize there are certain types of clinical signs or clinical features of seizures that make it a lot more likely that this really is also an electrical seizure as well. So, for example, if a baby is having a focal clonic seizure, so we talked about that rapid phase and then the slow phase back to baseline, and that's happening rhythmically, then you should be treating that baby. Same thing with a tonic seizure. Again, normally this is a focal tonic seizure. It's not the whole body that's posturing. But if it's just like the right leg that just becomes really stiff with that sustained increased muscle contraction for several seconds, then again, this is a seizure that you should be treating according to this study. Like this table shows, if there is a suspected seizure, but you can't quite prove it, then you should not be treating that baby. And again, like we always say in medicine, unless you really have to give something to a baby, we don't want to give it at all. And we know that there can be bad effects from just giving the anti-seizure medication. So if we can avoid it, we definitely want to avoid them. Okay, now go watch the second video on how we actually find out what's causing the seizure and how we treat the seizures. Again, if you are interested in neonatal education, then please subscribe to this channel. If you want a say in which videos that we publish next, as well as if you want to join this really fun community, then please think about joining our membership. Again, thank you so much for being here.